let's begin. As we're looking at what we're trying to do, even if you study the charts and understand something about navigation, collect all the data is not always the same on any given day on a given patient. Sometimes, based on the health of the patient, the details of the patient, the concerns of the patient, everything changes, even though some of the initial data that you've collected looks the same. And so as you start to put this together, looking at the biologic pieces will never go out of style. And so it's really incredible to be so thrilled and so excited about what Christian showed, the future. It's enough to make our heads spin, and we're just struggling to figure out how we can incorporate it. My essential hour that we have together is really to focus on one patient, Bonnie Ann. Bonnie Ann has some challenges. She's been a bulimic since she was 12 years old, has no real source of income, limited budget. I'll explain that this winds up to be a scholarship application that you'll see later. But the idea, when you look at it, what do you see? What are you thinking about when this patient comes into your operatory? Because in the beginning, I was thinking of maybe we're going to use some implants on the upper second bite to the upper second bite and restore the rest of the teeth. She also was quite a phobic patient, needed to be put to sleep for every procedure, even to do a single restoration. So it started to get more complicated. And how are we going to incorporate some of the disruptive technology that exists? And trying to grow within our practice is not that easy. I've struggled with this all the time. And so I'm going to give you a sense of where we've come from another field, and this is also in car racing. This is from the Indianapolis 500 in 1950. It's only 67 seconds long, and it's painful to watch.
Only 4 crew members, including the driver, are allowed to work on the car. It's a tense time. Holland stays in his seat, anxious to get away. Let's watch. Tires are changed at last. A crewman polishes the windshield as Holland moves away just 67 seconds after he stops.
That's almost painful to watch. And part of the problem back then is they thought the people that designed and built the car would be the best people to manage the pit stop. But they weren't trained to do that. As we start to move into digitalization, we also have to start to disseminate who does what in the practice. Back in the 70s, the outcome of that was Pit Crew University, people that were just trained to complete this task. And with the training, look at the precision and efficiency, look at the difference. Here we go. That's the preparation. Done. It's unbelievable. The world's fastest pit stop right now has been recorded at just under 2 seconds. Realize they're doing the same thing, changing the tires, cleaning the windshield, filling the car with fuel. If you watch it in slow motion, and start to understand a little bit more, these racing cars have 30,000 sensors. Each wheel has 8 sensors alone. Watch the foreman handling the lug wrench, lug bolts. They already engage them before the car comes to a stop. They're trying to pick up every bit of efficiency they can. And they're using all the newest technology they can in order to finish what they were trying to do, the goal, the outcome. And it's orchestrated incredibly well. It doesn't always feel that way when we go back and practice on Monday morning. It feels clunky, sometimes we feel awkward. And so as you look at this, what we're trying to do now, when you go back to Bonnie Ann, what are you going to do? You've sat here for 3 days, you've seen some incredible content, absolutely incredible. But remember, as you begin to train and become wiser, I love this quote from Suzuki, in the beginner's mind there are many possibilities, but in the experts there are few. And so being able to really understand where you're taking this patient from the moment you meet this patient is not so easy. And so the point of this is when you look at Bonnie Ann, which you will, in the beginning, I was going to do something else that didn't turn out to be exactly that, because as I got to know her, as I began to understand her risk factors, her limitations of treatment, it became a full mouth implant case. And I will show you what it looks like. Even though you have the technology is not making all the decisions for you. It's creating an asset for the decisions. So in 2016, we used the first scan, which was the TrueDepth scanner. And then in 2017, I used a different scanner, that's the 3Shape. But you already know we have the ability to superimpose the scans. In the 19 months that I knew her, she was already losing tooth structure on the incisal edge. They're that much shorter in 2 months alone. The teeth were just breaking down and destroying themselves right before my eyes. If you look very carefully and look at the facial composite on the upper right central, you'll see there's some tooth structure beyond it. When you look at 217, it's almost flush with the edge of the tooth. Things are happening that fast, she now has an anterior open bite. Subsequent to this time, she's been in rehab and some other things to help her. What I use to help understand where the face goes is I designed these reference glasses. They're really inexpensive. You just put them on the face, they help you orient the photography, they give you known references, and they help you then orient the occlusal plane first, live, before I put it on the scan. Because as we heard today, being able to control natural head posture, being able to understand what we're doing is critical. Now the problem is, when you're looking at implants, you're dealing with static data. Where is the bone, where you're placing fixtures relative to landmarks. But when you're dealing with the face and you're dealing with occlusion, you're dealing with dynamic data. The lips are moving, the jaw is moving. It's not so easy. And digital protocols don't always capture those pieces. And those are the pieces that could create a very stormy outcome for you. And so my way of getting this first digitized is to use, this is a face bow system. I don't have any conflict of interest in terms of the money. It hooks up to a simple laser. It's a $200 bow and will link with any articulator system in the planet. It's by Panadent. But then we take the records, and instead of trying to put them in the face on the virtual articulator, we put them on the FaceBow system first. And once it's on the FaceBow system first, it's then positioned in the virtual articulator. Now I know it's perfect. It's perfect left to right, it's perfect front to back, and even with a CBCT scan, we make no mistakes, because as you saw today, being able to position the head, even in the technology, has a source of error. So what we're doing is we're figuring out natural head posture ahead of time, so we have less errors. Then, what happens? This was all done by DSD system. This is Christian Coachman talked about it today. Actually, Francis Coachman did all the design. When he did the design, I had never seen some of the things that I saw him do, which made this an incredible opportunity for us. I mean, today I've been exposed to different systems, but when we did this, a lot of those systems didn't exist. And you're well familiar with the aesthetic mock-up, which is an incredibly motivating factor for these patients. And so the difference in this case is all of the soft tissue problems and bone are in the way. It's not so easy to plan for this until you know where the bone is going. Are you just going to slice all the bone away? Just go in there and level the ridge? Will you have enough left for implants? Not so easy. So this was designed with a template from the DSD system that would just go over the teeth and over the tissue, as if the surgery was already performed. No surgery has been done. That little pink display is the soft tissue component showing through. Now, at this point in time, you could provide any type of restorative dentistry. We're going to move, because of the shared risk factors of the patient, we're going to move toward an implant-supported restoration. Now, it gets really interesting. What Francis was able to do, and you'll see the video, is take out the teeth on the scan. Now, I had never seen anything like this before, and it was amazing to me to have the teeth removed and then see all the extraction sites as if you had already removed the teeth clinically. Because up till this time, this would only happen in the mouth, and I would have to judge what would be happening to these sockets when these sockets would heal. So this was the first time in my life I was able to plan pontics into the extraction sites of teeth before they were even removed. Up until this time, this was only done as a direct procedure. Very tricky in bigger cases. How's that going to heal? How will you plan for this? All of a sudden, the best digital design plans will not do anything if we don't understand the biology. The teeth are already below the bone. Do you cut this bone off? How much of this bone will remodel during the wound healing? We also heard today about finding a position of the mandible. I use a deprogrammer. Remember, it's very dangerous to take a CBCT scan in just an MIP position. When you're designing the functional outcome, you have to understand where the mandible will go in some sort of reference position. And this has to be passive. And just to show you, the leaf gauge is not the same as the deprogrammer. And there was an error. And that amount of error that you see in the shift would be a disaster when you go to the mouth and try to get the arches to line up. So doing these things created huge learning value for us to plan, number one, where the teeth go in the face. Number two, how the teeth fit together. Christian talked about facially generated treatment. Now, what's the problem? At this point, how are we connecting the implants? What's the technology now for this to happen? You saw some incredible lectures presented in this regard in neck design today. I'm going to show you where we're going. Rather than wait for the end of the lecture, I'm going to give you an idea where Bonnie winds up. The idea is you may not be able to tell where the implants are or where the pontics are. That's the goal. How can we design the architecture the way we want it with an understanding of biology? Not just accept what happens, but drive it to the way we think it should happen. And if we could do that, what would we be able to do? How would we be able to predict that as an outcome? And so the idea of that takes all the science we have learned our entire careers. And so to put them together in one patient is my plan for the next 50 minutes. Now, the first concept, when you think about implant design and the emergence profile, you really need to go back to pontic design. Because an implant is a pontic connected at the base. So if we understand what pontics do to tissues when we place them in tissue, because there's no implant in that case, all we have to do is attach it. And so being able to understand that is the critical piece. I published an article in 2001, which was the 5 keys, which is the essence of this, which was selected as one of the 3 most significant articles published in the last 25 years at that time. And when you look at it, there wasn't as much science available that there is today to substantiate what this article was about. Because what I'm trying to focus on at the moment is the patient's presenting anatomy as being the deal breaker many times for your being successful or having a disaster like being in the perfect storm. Because many times you may not be able to overcome that. We heard about infection problems and other problems. Thin bone, thick bone. It all has a place. So the idea is to run through these 5 things and then revisit Bonnie Ann and see how you would make the decisions on your own, having a little bit of understanding of just these simple 5 things that become incredibly powerful. Now, this is risk management, and I'm going to tell you, if it's more on the green side, immediate implants, immediate load, many of the things that people show are pretty easy to do. But if you're on the red side, not so easy. And so the idea of the lecture is to provide a risk management solution. Now, I am certain there are many of you in the audience that are familiar with this tragedy, the Costa Concordia. What you don't probably realize is my wife was on that ship at that time. She was in a stateroom right back here. When that ship was in the crisis mode going over, they were not prepared. They were not truthful to people. People weren't evacuated properly. They were so close to shore, no one should have perished. But they told people to go back to their staterooms. It's going to be okay. And many of them couldn't get out. My wife was one of the last ones off that ship. And they packed people in those lifeboats way more than they should to disembark. And then the lifeboats, because the boat was keeled over, could not be deployed. So they cut the lines, the lifeboats free fell to the water, and it broke her back. So her back looks like this now. Those are implants. That's the size of that implant compared to one of our implants. So when we talk about risk management, they were completely unprepared for that event. And many times, this is the problem. We lose it when things start to go south during the appointment. So being able to be prepared and plan for the inevitable is the key. So this is the risk management. We have computer software to do that. That's one thing. And then you have the responsibility for informed consent. I mean, there's a lot of details that lead up to what's going on the screen, and I'm just presenting that. I heard comments earlier about oral hygiene management and what's going to change and what's to make sure the shared risk factors aren't continuing. And those are great questions, because they absolutely need to be managed. These are the 5 keys. Now, this case was done 25 years ago with an implant design that would be considered archaic today, typically smooth surface implant, machined implant, smooth polished collar, no neck design that we're talking about. It was not as an immediate implant. But if you look at the architecture, it's very favorable, and the outcome, even in spite of doing any sophisticated procedures, actually worked out very nicely. There was delayed placement, not immediate. It was not grafted. It was not platform switched. There was no provisional restoration placed as an interim. Why? Why does that look like that? Now, that doesn't mean what we have today doesn't offer advantages, but the key is, what advantages are they? What are the things that really make a difference biologically before you do the surgery? So what I want you to think about, these 5 things more than these 5 things. And to be fair, it doesn't mean they're not important, but the idea is they can't help you if the architecture is unfavorable to begin with. That's the point. And then the next point is, if it is favorable, what do you make sure you do to not create the problem? That's the point of this lecture. See, they do make a difference, but they don't have predictive value necessarily, which is why there's so much controversy. So being able to make better choices in the market, which now you can understand the MegaGen design and why it does what it does, but without understanding the architecture around the implant, that's not enough. Now, if you look at what happens when you take out a tooth, the first thing is, at what point does the wound healing stabilize? At what point would an extraction socket start to not change? And typically, if you look at the data and run it through the coronal, the middle, the apical third, at about 90 days, and I highlighted this for you, at about 90 days, the dimension of the site will look the same as about 180 days. Now, my point is, if you're going to try to understand what you're dealing with, there's going to be a need to wait 90 days in many of these pontic areas to ensure that the ridge is not going to collapse underneath you. Now, what's the next part to this? What the problem is, and you understand the concept of root membrane today, which is phenomenal, it's because when you remove a tooth, you remove the lamina dura, hence the root membrane concept or socket shield. Now, we know that is a certainty. It's not necessarily just being able to do this minimally traumatic, but once you remove the lamina dura, you will induce resorption that you cannot stop. So there's going to be a biologic compromise that you cannot stop. Now, I want you to be very careful. That compromise is not only on the facial, where the architecture is thin. It's also a problem in the interproximal, when teeth are especially close together. Now, the reason that that's important is if you have, let's say, teeth that are within 1 millimeter of each other interdentally, when you take this tooth out, you will get the same resorption on the inside of that architecture, which will affect the vertical height on the bone on the adjacent tooth. And that piece of bone is what I call the papilla maker. So what's going to happen, even though you do your best to remove this tooth, even though you do your best to manage the infection, you're already at a disadvantage based on the presenting architecture that you're not going to take care of. The implant's not going to fix it. Your grafting material is not going to fix it. Because if you lose that peak of bone, you will lose papilla height. Guaranteed. I don't care if you go immediate implant, immediate provisionalization. And there's a number, there's a metric to that. So the 1 millimeter distance or thickness is a critical one because it actually occurs 87% on the anterior teeth. 87% is pretty good odds even for Vegas. Just think about it. So in essence, what I'm saying to you, I don't need a CBCT scan to tell me that the facial plate is thin, because it's usually thin almost 90% of the time anyway. So my planning piece should assume it's thin all the time. Is everybody okay with that so far? That means when you get some resorption on the inside, it's going to affect the vertical height on the outside, which will have an impact on the facial freegigital margin. And the same thing will apply when teeth are close together. What's the next problem? This is why doing a socket shield technique, and I was amazed to hear 500 cases. I think that's more than anyone else in the world. That was very impressive to me. And so we do know that's a technique-sensitive procedure, and maybe that technique has really gotten worked out. I was very impressed with the thoroughness of that portion of the lecture. We also know when you place the implant, we typically place it more palatally because the palatal bone is thicker. We also know it's not necessary to many times graft the gap. So the thickness is an issue. And we know as long as it's within a 2 millimeter range, you don't absolutely need to graft it, but we graft it anyway. We graft it anyway to reduce any risks of the downgrowth of the epithelial attachment or the junctional epithelium. We also know that 1 millimeter deeper is going to be important because if you're going to lose that millimeter on the facial crest, if you don't place your immediate implant deeper, you will have an implant that has survival probability. That's not the problem. But you'll lose bone on the facial because it's going to shrink anyway with potential thread exposure. So in the data, it doesn't detract from the survival probability of the outcome. but it may lead to more concerns of peri-implantitis, peri-implant mucositis, if that area gets infected. Now, the point of this is what we heard also today about the concepts of biologic width. And absolutely what's been substantiated in countless papers is the design on the far right of the screen is a superior design to maintain crestal bone height. And the Megagen implant already has that design. It's already automatic. There's no need to platform switch. It's already built into the design of the head of the fixture. That's the genius piece. Now, the idea of this is if you look at the reference positions, they are very different. And why is that a problem? If you lose bone at the neck and your implant is close to the adjacent tooth, you're going to lose papilla height on the adjacent tooth because you're going to reduce the bone, which was necessary for your papilla maker. Now, just so you know, there's a lot of folks that talk about grafting or using the graft that's slowly resorbing to support the bone. That's what everybody talks about. If that was true, then the best graft in any extraction site would be an implant because it's rigid and not going to resorb at all, and the bone will grow around it. But in this case, what they did is they put bioos around the gap, and what you have to understand is the facial plate in these cases is in essence a moving membrane. It's a moving membrane that you can't stop. Why? Because you've taken out the lamina dura. And if you watch what happens in spite of the implant placement and the bioos, look at it, you can almost see through the tissue. And if you peel it back, look at the implant. It's all exposed on the facial. Now that implant will meet the torque requirements, have good ISQ, but it's not the same risk-wise going forward. So placement conditions can hurt you, but you're not going to override the architecture. So these are the things that start to make a big difference in planning. This is why typically smaller diameter fixtures are better for the biology as long as they're strong enough in many cases. So when you look at this, there's one more problem. It's contiguous extraction sites. What they did is they had three groups: a single one, a double one, and a triple one. And if you look at the ultimate bone-to-implant contact, it was significantly compromised just by removing contiguous teeth. So these are things that hurt you in spite of how good you are. This is the biology. And I get concerned because I don't want dentists to take a hit for something that they don't deserve. So we need to be able to understand how to manage that. So multiple contiguous extraction sites are even worse when the proximal bone is very thin. What would those be? Crowded teeth. Crowded lower incisors, when you take those out, you take a look at everybody's slides, the ridge goes to nothing, fast. And there's nothing you're going to stuff in those holes that's going to stop that. You'd have to come back to guided bone regeneration. So let's go through the keys and see where we are. We understand a little bit more about the consequences of biology, the wound healing. Now what can we do to judge? When you see this now, you see that tissue is already more coronal, already more favorable. That'd be on the green side. And what would mean other situations? If teeth are more lingual, the tissue's typically more coronal, and the facial plate is typically thicker. So in thicker facial plates, these are way better candidates for immediate implants because they're not going to resorb the same amount, and you can plan for that. On the other side, teeth very prominent, push through the facial plate, very dangerous cases because you're already behind the curve. Rather than try to build this up, you're already in trouble. That would be more of a delayed approach, or cover that up to then uncover it later. I published this with Keith Phillips about 20 years ago. We called this the ARC concept. What this also pertains to is your implant emergence profile. Same as a pontic. See, laboratory technicians many times want to make the pontic fuller to move the tissue out. The problem is it doesn't move the tissue out, it moves the tissue up. So the same thing happens with an implant. This is why everybody now talks about flat emergence profile, especially on the facial. I published that in 2001. And so if you wanted it to move up, you would make it fuller. So if you look at this emergence profile, which is very full and very big, as soon as you screw it in, the tissue moved up. And in this case, fortunately, that was a favorable outcome. And so, important message. The fuller the contour, the more apical the tissue. The flatter the contour, the more coronal the tissue. So if you get in trouble and you're trying to keep the tissue as coronal as possible, you need an emergence profile that's extremely flat. This is where internal connections are going to have an advantage, because you're not trying to get an abutment to fit over an external hex. It's very important. What else happened as a precursor for those cases that were already at the same position when you're removing a tooth or already facial? This is where we tried to use orthodontic extrusion. And I know Maurice was here earlier in the program. This was published by the Salama brothers 25 years ago. And it's a very effective way of coronally positioning the tissue. And by the way, this is from a journal I have in my practice that was published in 1883. So vertical movement is not new. Now, the idea is very important in terms of what happens when you're vertically extruding a tooth you're going to remove. So you need to be careful. So remember, it's hard enough to get adults to do orthodontics on teeth they're keeping, let alone do orthodontics on teeth you're planning on extracting. So here's a nice way, a nice verbal skill for the patient. You know, Mr. Jones, this orthodontics will only take a few months, but it may make the difference for the rest of your life. See, this is a powerful way to frame the story, to frame what you're about to do so they don't just get so worried about the next few months. So we explain to them, if we move the tooth coronally, you know darn well you can move the architecture coronally. Not a problem. The problem is going to be when you lose the tooth. Remember, what's going to happen here? The same thing of losing the lamina dura. You're going to get resorption of the inner lining that you can't stop, which is going to take the peaks away and shrink back the facial. The difference is, in this case, the facial would shrink back to where you started, which would be a good thing, so you wouldn't have a facial defect. But to keep in mind, when you erupt teeth, you don't get to preserve that coronal peak. It's going to melt away. So what's the take-home message? When you're dealing with implants, the key reference position for the papilla is not the bone you're removing or not from the implant head. It's from the bone on the adjacent teeth that you're keeping. Those are your papilla makers. Those are your papilla maker. So you could have an implant that's deep in different positions. It's that peak and that peak that supports the papilla. When we move to scallop, it's really confusing sometimes what scallop is, because many times when people look at scallop, they confuse high scallop from facial recession. The meaning of that will be something like this. If you look at the skull specimens, most dentists would call that a high scallop. That's not a high scallop, that's actually facial recession. This is how we do aesthetic crown lengthening today. We move the facial up, we leave the proximal bone alone, and we wind up with longer teeth and no black holes. But if you look carefully on all three of the images, the inner dental bone is all in the same place. Very important. So my point, high scallop to me is very coronal position tissue. A high scallop is a patient that would wind up potentially with a black hole when you take out the tooth. And the problem is most of us have not been trained well enough to even recognize what it looks like. Only 50% of dentists are able to identify biotype and scallop. And that's not just necessarily us being wrong, it's because we haven't defined it very well. Without clear-cut definitions, we use terminology that doesn't always mean the same thing. So let me help you. When you look at thick tissue now, how can you define it? Well, years ago, I would joke that thin tissue is when you can see a periodontal probe through it. 20 years later, the data surfaced that said that's actually true. That if you could see a periodontal probe through the tissue, it's thin. What thin means came out later in this paper. This is the paper on probe visibility, which was associated with gingival thickness. It's a metric. And the point was, if you will look at Joe Can's work and others, what that means is the tissue is less than 1 millimeter thick. Now that's important to you because if you use metal abutments, it's going to show through. So probe visibility through the tissue is currently the simplest and most reliable method of determination. It's not a CBCT scan. Trying to collect that data in that way is too tricky. Now, what most people try to do to thicken the architecture is go to manage bone. What the data says is you're better off using connective tissue. It's more predictable, easier to make it thicker, and more importantly, it's very stable. So connective tissue grafting is critical to manage thickness issues in tissue if you have a problem. So I would suggest to you that being well trained in doing connective tissue grafts or alloderm grafts is very helpful in order to manage that architecture. Now let's put this together. It's about 10 years ago, it's a school teacher that was in my practice, a person of very modest means. She came in with a tooth I couldn't restore, so I did what we did a lot of back then, which would be orthodontic extrusion. I explained to her we need to move the tissue more coronally because when we take it out, it's going to shrink. There's a biologic consequence, and we need to do this, and she did it. So at that point, I referred for implant placement, and the surgeon placed the implant a bit too far to the facial. This is why facially positioned implants and not deep enough implants are really a big problem. And no implant design is going to be able to get you out of this trouble. So the implant's uncovered. The left central, we make final impressions and a posting core. I send it to a good quality lab and it comes back like this. I'll never forget this day because I'm looking at this still thinking it'll be okay. It has to be okay. Until I ask her to get up out of the chair and look in the mirror. It's a disaster. She had all she could do to stop from crying her eyes out. Just think, a school teacher, modest means, this is a year later, she did everything I asked. But there's a solution. What have we just talked about? Thick tissue with a connective tissue graft. Flat emergence profile instead of full emergence profile to change the position of the tissue. I took the restoration off, put in a cover screw, and regrafted it. Let that heal for 3 months with just a removable retainer. At 3 months, I opened it back up from the lingual, flipped the tissue out to the buccal, and reconnected the same abutment with an altered coronal shape of the restoration. So just remember, it's the same implant with only an extra connective tissue graft and changing the coronal shape of the restoration. This concept, remember, flatter is more coronal. And look at the difference. Placing it in, and now look at the restoration. That's the same implant, the same thing. The power of being able to control the biology, because the biology can hurt you if we don't understand it, and the technology is not going to override the problem, no matter how good you are, if you don't understand concepts of emergence profile, tissue thickness, architecture. Now we'll go tooth shape. The consequences of tooth shape are not difficult. In essence, the more triangular a tooth, the more incisal the contact point. These are really tricky because if you lose any tissue on a tooth shape like that, you're going to have a black hole, and people don't want black holes. So you know as well as I do, doing a single tooth implant in an environment like that is a big problem. Many times we're doing multiple restorations to reshape the teeth and drive the contact points more apical. So the data indicates the real difference between triangle and squared teeth is the position of the contact point. That's really all it is, which means the papilla should be in the cervical third of the tooth. If the papilla is in the incisal half of the tooth, that is a disaster waiting to happen. Everybody okay with that so far? What I'm trying to do is help train your eyes. Now, what I can also tell you is many people will tell you if you squeeze on this tissue, you can get it back. The data does not say that. They looked at embrasure morphologies. They did not change the papilla height. It's not going to get you as far back as you think. So the concepts of grooming are limited. So I'm going to show you how we manage that. It comes down to this piece at the end. This is what in the beginning, in 1994, when I published this, I called it sounding to the osseous crest. It's not a term that really caught on in dentistry. People now call it transsulcular probing. And in the beginning, people would tell me, you shouldn't do that, it's going to hurt the tissue, it's traumatic, and I've never found that to happen. And so I published this in 1994 using the total dentogingival complex as a metric to predict what would happen when you restore teeth, crown-lengthened teeth, and now it will apply to implants. Some of that you heard earlier today. Long hair lecture, short hair lecture. I got a kick out of that, Scott, actually. So just to show you, this is the problem. Forget the data at the moment. You see, the tissue position is the same in all three cases, but the bone position is not. So if you don't see the bone, which you can't, and it may not be registered on the CBCT scan so easily, this is where you can have trouble, because what does it mean? The further the bone is from the tissue when you start, the more likely you'll have bigger changes in the tissue when you take out the teeth. Dehiscence, fenestrations, all these things will result in consequences. And the data backs it up. My original data of 3 is shown in over and over again on the facial. The other piece, if you take a look at this, we published a recent one, even after we took the teeth out and directly went to the crest, it's the same. It's at 3. If you look at the number, 3.19. Now, in the interproximal, the data has the same problem. The further the distance the tissue from the bone, the more likely that tissue will shrink more when you take it out. But most people follow Dennis Tarnow's paper in 1992 that says 5 millimeters. I don't. We're not looking for the mean. We're looking for what's most likely going to be present after you take out the tooth or after you pack the cord. So my reference data has always been 4. If you look at all the data subsequent to that paper, they will tell you 4 millimeters will work 100% of the time. 5 millimeters will not. It'll be 75% of the time, 58% of the time. Because it also is related to the distance between the teeth, which I'll get to in a second. If you look at this, I published this with Joe Can also. Between implants and teeth, the numbers are very similar. If you look at the data, bone sounding around next to implants is still 4 millimeters as the metric. And over again, all the other people say the same thing. There's single tooth implants, the data is 3.93. And so my metric is 4. Now let's put it together. If you take this tooth now, and you look at it, it's a triangle-shaped tooth. It's got 3 on the facial, 4 in the proximal. What that means on this tooth and on the lateral, I could take this tooth out. I could take this tooth out, use this as a metric, this as a metric, and it should be okay. I'm taking an interim partial denture, nothing fancy, with the exact shape of the tooth that I started. I'm predicting that that papilla should not move if I only support it. I don't have to squeeze on it. And so it's an interim. The tooth is taken out. It was a little bit tricky. That comes out. The guides are crude, old school. Implant went in. The flipper goes over the top. But I can tell you, it supports the tissue. And that's the interim partial denture. That's the final restoration. 25 years ago, it's a metal ceramic crown. Look at the papilla height. We lost a little bit on the distal, a little more on the distal because of the root proximity. But other than that, it's very reasonable. So take-home message. Number 1, we definitely want to use your implant guides to position the fixtures. My recommendation is obviously the same that everybody knows. Stay away from the adjacent teeth, 1 to 1.5. So even if you get some change at the reference position, you don't lose proximal bone height. Don't use larger diameter fixtures to fill the extraction sites. Stay smaller. They'll fill with blood. But be careful. The downside with smaller is the strength. I've never found a problem with the megagens. They're plenty strong enough. Implant position should be facially 3 to 4 millimeters apical to the ideal free gingival margin. This is going to be important when we go to Bonnie Ann. Bonnie Ann at the time of surgery is not at the ideal margin. It's the margin that I predict the tooth length to be now 10 millimeters. So once I get up to 10, then the head of the fixture has to be 3 to 4 millimeters more apical than that. And this is where many times we have a problem in planning. You also heard today about going back 4 millimeters off the facial. All this is easily designed with the technology. And so now what happens? Once we figure this all out, now we do the surgery. This is the greatest day of my practice life. Why? This is my son. My son is also a prosthodontist and has implant surgery training with Dennis Tarnell. And this is the first case we could work on together at the same time. He's a lefty and I'm a righty. And if you've ever had a chance to work with someone in your family, you know how gratifying it is, and I will never forget this day. I worked my life to have that day. It was an amazing day. It was more true. Thank you very much. We really struggled to take these teeth out. Christian was actually there at the center when we were doing the surgery. I know people say they could get the teeth out easy, but it took us over 2.5 hours to get all those teeth out. They were like rocks. I could tell you it was not easy. And we're afraid of fracturing the facial plate and all the rest. But the best thing about being there with my son, we could help each other as we would get a little bit tired. The other one could take over. It was just amazing to me. We did everything. We spun the blood. We captured the biologics. We also used a tooth grinder, by the way. I really like this smart grinder. More and more people would prefer their own biology being put back in their own mouth. So we took out all the teeth, took out all the restorations out of the teeth that were left. They were all ground up. The whole system comes with easy instructions to follow, that it makes great grafting options for all the socket sites that we're using as Pontics. They worked great. So I really liked the smart grinder. It was fast, it's easy to do. And the protocol for this, by the way, is very simple. I mean, it grinds for 3 to 4 seconds. You have to clean it. It's a soak, a 10-minute soak. But you could become your own bone bank. If you look at the data, it's very compelling about using tooth structure as graft material, how it turns over and stimulates even BMP growth factors in the sites. It's really quite effective, and we've had no problems with this. There we go. So what we did is that the DSD system then went ahead and we used the click guide. I think Christian told you about that. You saw that. This worked beautifully for us because the click guide goes on with the tissue in place. We fixate the structure underneath so it stays in place, and then you can place all the implants, put in to jump your abutments, and then the provisional goes also in the same guide and clicks over the top. And then I could do the rest with the restorative options. But see, here was the challenge in this case. When we put this together, you can appreciate, here's the plan. You see, here we didn't have the room. The idea was to predict the biology of where the tissue would wind up after complete wound healing, which would be now over at least the next 3+ months. So we did immediate implants, immediate load. When we put it in, this was the prediction of what it would look like. I told the patient it would not be attractive, the teeth are going to look short, but it's going to be okay. When we placed it, that's exactly what happened. The teeth are shorter. This is not the day of the surgery because she was completely put to sleep. I waited another week for the photos so you could see the teeth are short, they're not at the final length. But waiting, just waiting alone, the provisionals went to their normal length. And so we just waited for the biology to change, and it worked. Predicting it all from the DSD Design Center. Francis Coachman predicted all of this by placing the Pontics in the extraction sites at the time. And it was so gratifying to see it work. Then at the end, we went back and redid the scans. This was the original scans and then the implant scans. Then we could compare the scans of the implant locations that were planned for versus actual. And as you heard today, they were not exactly identical. This is why we still worry about safety factors of a couple millimeters near vital structures. Be really careful of the limitations on some of the technology. It's getting there, it's amazing. It's helped me do so much more than I ever could before, but we have to understand the biology. I mean, this case, to be able to do it all in one day, was an amazing opportunity. And I don't think it was possible without the technology. And it was fun. That's the hard part to even talk about, because you can't imagine how much fun it was, in spite of all the stress it was. And so being able to transform the patient is one thing. And by the way, one of the things about being able to do this for Bonnie Ann, we did go back with conventional impressions. I totally agreed with Jonathan's assessment. I didn't have the micro CT, but we're still, for the bigger cases, I still do that. But the point was, the models were groomed by the provisionals. And all we had to do is rescan this and then put the finals in. I wasn't as forthcoming. I didn't put zirconia in first. We went with PMMA. That was our strategy. And then I'm going to tell you one other thing. This is the any ridge. At the time of uncovery of the implant in the back, one of the molars, when we went to make a final impression, it was loose. The any ridge saved the day. By being able to use that implant as an immediate implant and still go ahead with the final impression the same day was an amazing saving grace. Because having to put the patient to sleep and think about all those other ramifications were really frustrating, but it saved the day. And now you could see from the top, all the whole thing starts to fit into the tissue as it's grooming the tissue. And then the final restorations start to fit and start to come into place. The point was, these are all pontics in the front. The implants are in the cuspid sites, the second bicuspid sites, and the first molar sites only. And the rest are all pontics. It's a zirconia restoration, which has its share of liabilities as well, fracture potential, crack potential, as you're well aware of. And it's fairly recent, obviously, but I do recommend the night guard option. I thought that was a good recommendation earlier today. And to be able to have a patient that can come back into society, reorient her life, because she's been through quite a bit, was a very gratifying opportunity for us and certainly for her. But one of the things to never forget, even being able to give back, it was a tremendous learning opportunity for us. Because for us, being able to use all the technology and work with a patient that was very cooperative and understanding, even though we weren't getting compensated by money, we were being compensated by much more than that. It's changing someone's life. It's a gift for humanity. And giving me an opportunity to put something on the screen so we can share the learning value of doing something like this and figuring out how we're moving forward. The world is changing so fast. It's not only in the automotive world, it's in our world. And you know, a famous quote from Mark Twain, even if you're on the right track, you're going to get run over if you're standing still. And so we're working very hard to keep changing, evolving, and growing. And that's why I'll leave you with one of my favorite quotes as you think about what we were able to do on Bonnie Ann. And that quote is this, from Albert Einstein. Wisdom is not a product of schooling, but of the lifelong attempt to acquire it. I want to thank you all for staying with me till the end of the day. And thank you for working so hard to be better. Because that's the one thing that brought us all here, to be better. And I will tell you, the one thing that dentists tell me when they come to the teaching center, things like this. I practice in a small town. My patients are my friends. I see them in the grocery store. And when I see them, I want to be proud of what I've done.